sling in halfway and it starts bleeding, and then we can't do it. Like, this is not going to work that way. I don't feel comfortable doing that just because you keep saying it's fine and you'll sign whatever paper. But no.
Right. And on the other extreme, like doing a first trimester abortion and somebody insisting on like general anesthesia.
Yeah.
Like the risks of the anesthesia versus the risk of this procedure. It's so rough.
It's an interesting population you deal with. It's like, I also like, work in VAs and things like that in the county hospital. And even the VA is like, whatever you say, doc. Okay, doc.
Yeah.
Make me better. Like, I will.
That I will work with. God, so what do you think she ended up doing?
For that lady?
Yeah, it's just being incontinence for her.
Well, it's just stress incontinence. It's not the worst thing in the world. And
Right.
I was like, I'll get you to somebody who feels comfortable doing it, but I don't.
And also, like, if she had come to you before the surgery to have a conversation about what are the possibilities of doing it like this, I've got some techniques that I think I can self-hypnotize, whatever.
Well, she was saying, like, what about anesthesia? I'm like, go. Like, we'll talk to the anesthesiologist because I can do like lots of different options. But the fact was, she was telling the anesthesiologist she couldn't use any fentanyl. You can't use any Dilaudid. And she had like a list of drugs. And the anesthesiologist is like, well, I don't have anything I could, give you any pain relief. I don't. Well, he's going to use local. That'll take care of it. And I'm like,
And that's the kind of patient that's going to wind up suing you no matter what, right?
she was so mad. She sent all these nasty letters to my office. She started calling me. It was just fun. I was like,
Yeah, drama.
yeah.
Okay, microphone. How do you feel about? Here's the thing.
So what?
It works, but like if you flip it and then you turn your head to look at the screen, it's not gonna work. I always just end up holding it, but you've got a tie. You could probably. You know what? Your choice. If the battery runs out, it's on. Do you want me to introduce you, or you want to just introduce yourself? You're probably better at it than I am. All right. If you finish early, great. Oh, and if you at the 50-minute mark, we give them a break.
Yeah, that makes sense.
Awesome. And I'll give you a little signal if we're getting close. And you look so deep in the best.
Good morning. Can you guys hear me? Is this thing? This is not on, is it? You sure? No. Ha! No.
Yeah, it's on. Let's see about the.
Because
Good morning. Good morning. Volume. Wireless. Good morning.
All right, cool. Good morning. So, this is my first lecture here at Toro, and so it's nice to be here. And you guys are a second-year class? Okay. So my name is Hercule Cara. I'm a urologist. I have a private practice in Napa. I also work out of the North Bay Hospital. And we're going to talk today for hopefully less than 2 hours about lots of different urologic things. This is somewhat of a urologic hodgepodge lecture. We'll go from different topic to topic, and this is the stuff that you would see in a clinical setting. So this is not necessarily stuff that you wouldn't see just as a primary care doctor, and there is also value in learning a lot about these things, because as you will progress along, no matter what field you go into, you'll always be a doctor, and it doesn't matter if you're a pathologist and you have no patient care. You'll have friends and family that'll call you up and ask you obscure things, and you'll dig back to when you were in medical school and try to answer what to do about their 3-year-old who has a swollen scrotum, or they're having excruciating kidney stone pain. What should they do? So Let's get started. So the first half of the lecture, we're going to be talking about a lot of variant conditions. There'll be a few slides on each topic. We'll talk about some gynecomastia, which is something you'll see in all fields of medicine, but we can see how it pertains to urology. Disorders of the penis, scrotum, testes, a lot of different conditions, including acute problems, problems of childhood, carcinomas. We'll talk a little bit about hypogonadism and intersex disorders, and then some sexual dysfunction. The second half of the lecture will go more into prostate issues, and we'll try to touch on some kidney stones too. Right, so we'll start with gynecomastia. So what is gynecomastia? That is a male accumulation of breast tissue. It can also be fatty tissue. The thing to distinguish is when this is pathologic versus physiologic. It's physiologic, meaning a normal part of the existing process. So newborns are typically going to have some degree of gynecomastia as a result of just an imbalance of the estrogen testosterone levels. So the general cause of gynecomastia is going to be this relative excess of estrogen compared to a relative deficiency of circulating testosterone levels. So getting back to what it was, we talked about there's going to be newborn gynecomastia, which child will be born. There might be some breast tissue there. That'll typically resolve within the first few months of life. Nothing pathologic there. During adolescence, as the testicles are enlarging and there's going to be a testosterone surge, there's going to be some imbalances of estrogen levels, and there can be a physiologic gynecomastia. And then there's going to be part of the aging process, what we call elderly or senile gynecomastia, all pretty normal. Another thing to recognize, and when there's a need for further workup, would be the pathologic conditions. So most classically, there's value in recognizing what medicines can cause gynecomastia. And oftentimes, if you don't mention it to the patient, they'll just not make the connection that this medicine you started them on is causing enlargement of the breast or painful breast tissue. Classically, in the urology world, that's anti-androgens. So one would be like a 5-alpha reductase inhibitor, and we'll talk about that in the second half of the lecture. But that's Proscar, which is finasteride, or dutasteride, which is Avodart. Or in the 1/5 dose of these medicines, it's Propecia, which is for hair growth. That can cause a breast enlargement and painful breasts. Other things that can be associated with this, Tagamet, cimetidine, an H2 blocker, spironolactone, antiretrovirals for HIV, metoclopramide, digoxin, tricyclic antidepressants. And testosterone replacement will be causing this too. Seems counterintuitive, but it is causing a great imbalance in the levels of testosterone, and consequently there can be conversion to estrogen, and this imbalance can oftentimes be associated with developing gynecomastia. Other conditions such as cirrhosis, hyperthyroid, and then obesity. Obesity is a very common cause of gynecomastia. So a mechanism of that happening, there's an aromatase in peripheral adipose tissue. So testosterone is going to get converted, circulating testosterone is going to get converted by that aromatase to estrogen, and consequently you have a kind of a negative feedback loop on the testosterone levels, as well as the development of this gynecomastia in someone with peripheral adipose tissue. One other pathologic condition to consider would be germ cell tumors. So typically these will be of the testicle, but they can be found in other parts of the body as well. And these will sometimes be having hormonal imbalances. Important to do a workup for at least a testicular cancer. An examination of the testes is in order if someone's complaining of gynecomastia. Some hormonal studies that would be positive, but not necessary just for standard gynecomastia, particularly if you think it's physiologic, you would notice a decrease in the FSH, LH, testosterone levels, and an increase in the estrogens. And if you actually did some testing, you might see an increase in 17-keto steroids. So what do you do to treat that? Probably the underlying problem, address whatever the underlying issue is, it be the medicines or the cirrhosis or hyperthyroid, or if it's testicular cancer. Using estrogen blockade sometimes can be helpful as well. All right, so we'll move on to the next topic, hypospadias and epispadias. So hypospadias is exactly as it's described, hypo, on the undersurface. So here's something you can actually take away from today. So the ventral surface, when we're using directions in medicine, sides are important in trying to understand. We don't really say underside or backside of the penis. We would call this surface the urethral side, the ventral surface, and we would call this surface the upper side, the dorsal surface. I think back to somebody in medical school who sat next to me first or second year who started laughing when she realized that it's basically describing an erect penis, the ventral surface and the dorsal surface. It's kind of contrary to a flaccid penis. So hypospadias is going to be something that will be noticed with an opening typically on the ventral surface of the penis. So the urethra is going to be formed by two mechanisms. One, there's urethral folds that are extending out embryologically distally, and they're going to form a tube on the ventral surface of the penis. Now, on the distal end, and you may already know this, and so I don't want to belabor basic embryology, but this is an important point just to understand the anatomy. On the distal end, there's going to be an invagination of the ectoderm, so the tissue that's ultimately going to become the epithelium of the corona and glands, is going to invaginate. Now, these 2 points, this urethral tube that is extending distally and this invagination, are going to meet. Now, in the event that they don't meet, that the true urethra, the thing that's connected to the bladder and the urethral tube that's coming along, stops short, it'll open typically on the undersurface, the ventral surface of the penis. What you will see is that invagination on the distal end of the penis. So it looks like a true meatus, but it's not. It's a blind-ending pouch, and the true meatus will be underneath. So this is a valuable thing to look for. Just confirm that, yes, even if there's a little hole in the tip, is that really the true meatus? Look at the undersurface and see if there's another hole. So about 70% of these hypospadias will be glandular or coronal. They'll be distal, but they can, hypospadias, anywhere there's an arrest of that tube, you can get the opening there. So you could have it on the proximal end of the penis. You could have it penile scrotal. You can even have it proximal to the scrotum on the perineum. You could have a bifid scrotum as a result of that. So lots of different places. The incidence is about 1 in 250 to 1 in 300, pretty common in the urologic errors of development. One risk factor could be the use of estrogen or progesterone by the mother during pregnancy. And what's an important point when we're seeing a hypospadias? Don't circumcise. So ultimately, if this is surgically repaired, that foreskin is very valuable in the repair process of mobilizing the urethral tube, creating a distal remnant or distal new tube. This foreskin serves as a vascularized pedicle. It can be moved, mobilized, flipped around to the other surface. So important not to circumcise. A typical appearance of a hypospadias will not be like this. This is a little bit overly simplistic. Instead, what you're going to see is a big dorsal, so up here, hood of foreskin. It's almost going to look like a lion's mane. So it's not going to look like an absolutely normal penis. It's not like, oh, this is a mystery to try to find out who has a hypospadias or not. It'll be kind of a funny looking penis, and so it just warrants looking at it a little closer. And what's the problem with having this? Well, if it's a very, very distal hypospadias, meaning millimeters or less than a centimeter from the actual tip of the penis, not too many problems. There probably can be adequate voiding and deposition of semen, and so that's not the biggest concern. You can get sometimes stenosis, tightening of these meatuses, and that can need to be dilated. But when do we want to talk about like surgical repair? Well, there's the cosmetic aspect to it, but more so as the true meatus gets more and more proximal, things that you're going to see is a need to sit down for the child or even adult to void because of the spraying downwards, and consequently a lot of that spraying and mess. And like I said before, if the opening is way proximal, we're talking shaft or coronal, the capacity for ejaculation into the partner and for fertility issues also becomes a concern. So oftentimes better to get this repaired younger. The tissues are more pliable and receptive, and the chance of complications less. All right, so epispadias. This is a much more rare condition and much more pronounced and quite obvious. So 1 in 120,000 males will have an epispadias, and 1 in 450,000 females. It's not going to be as kind of simplistic as we see here, but this just gives you a general idea of where the opening would be. Instead, you're going to have a big gaping opening, typically like a slit-like appearance. And there'll be glandular epispadiases, which are going to be more distal. So just anatomy reminder, that, this is the glans, this is the shaft, this area over here is what we'd call the corona. So glandular epispadiases, and then there will be more proximal ones. So we would call them penopubic. And those more proximal ones are generally associated with other conditions like bladder exstrophy, which means the anterior surface of the bladder failed to open. These are pretty significant errors of development noticed immediately at birth and generally require early surgical repair. What would be the goals of repair? Well, obviously, closing the bladder and moving the urethral meatus more distally. For a more proximal epispadias, there's typically going to be problems with the sphincter. The opening of the bladder is essentially going to be, or opening of the urethra is going to be proximal or involving the external urinary sphincter. So even by moving the opening more distally, we oftentimes do not get full continence, but there's more capacity for other surgical interventions for continence. Cool. So this is a kind of interesting topic. You'll get the guy that cuts my hair. It's an Irish guy. He leaned into me last week and said, well, what about this? So Peyronie's disease. So this is first described by a Frenchman in 1742, Francois Peyronie, and it's been around for a long time. And if you kind of do a little search, you'll start finding, oh, there's people that in history that may have had this, and what exactly is this condition? So it's a plaque. It's a fibrous plaque on the tunica of the penis. And I wanted to bring a visual aid, and I apologize. I was trying to look for a balloon so that I could, and I was going through my daughter's kind of toy collection. I couldn't find one. But the basic principle is this: by having this fibrous plaque deposition on the tunica, you get an area of the penis that's not going to stretch. So at rest, it'll feel a little bit firm. When the penis is flaccid, you can sometimes feel something there. But when there's an erection, this is going to be an area of tethering. The penis is not, this tunica is not going to stretch. The collagen deposition, the scarring, whatever you'd want to call it, is not stretching. It's serving as a pivot point, and you can get a degree of bend. It can be mild, like a 10-degree or 20-degree bend. It can be as severe as something like 90 degrees, even more so. So what's the basic cause of this, and what do we do with it? Most commonly, it's going to be idiopathic. The assumption is it's some kind of microvascular subclinical trauma that happened to the penis. No one ever recalls anything specific. Once in a while, there'll be a classic story of somebody who had a fractured penis, that they were having intercourse, and then there was a snap. The penis turned into a big purple eggplant, went to the emergency room. When everything healed up, now they've got this firm area on one part of their penis, and it bends funny. That's one of the more dramatic circumstances. But most commonly, we're going to see Peyronie's in individuals that just say, I don't know, this just started developing. It was 10 degrees, and then this, and now I'm seeking care because it really bugs me. Other times, it's going to be pretty mild, and people just don't know what this is, and they want to get it checked out. Some complaints could be, in addition to the bending or feeling this firm plaque, is pain with the erection, and that pain with the erection can lead to erectile dysfunction, or distal to the site of the Peyronie's plaque, they can have some degree of flaccidity of the penis. So this plaque is affecting some of the erectile tissue, and consequently there isn't very good flow into that area. So proximally you'll have an adequate erection, but distally, particularly on that side, it would be lacking. There is an association with Dupuytren's contractures, which kind of makes sense if you think about errors of just kind of collagen and scar deposition and whatnot. And microvascularly, if you look at these plaques, they're consistent with severe vasculitis. They can get pretty significant over time. You can get calcium phosphate deposition. They can be very hard. I've been in a circumstance where we're surgically removing it, and I couldn't get through this even with very strong scissors. Ultimately had to use the orthopedic bone cutters to cut this thing, the plaque, off. There is also an association with diabetes, with mellitus, with this condition, and gout. And what would be the treatment? So conservative management would be telling patients that they can just kind of monitor it if it's 10 to 20 degrees, and it's not affecting the capacity to penetrate, and they're having adequate erections, and there's no pain, to see what happens. Vitamin E and some other medications have been considered therapies. The success is really limited. The side effect profile is low, so I don't have any problem with patients taking about 800 to 1,000 units of vitamin E divided over 2 or 3 doses. But I give them a fair amount of warning that only about a third of people will have a response to this. Most recently, there's an intralesional collagenase that's become available and FDA approved, so literally injecting straight into the plaque. It can take repeated injections. There is a risk of a subsequent rupture of the penis and needing a surgical repair if that happens. And then lastly, surgical repairs would be typically removing that plaque and then replacing it with some sort of graft. We've used a variety of different grafts, denatured porcine pericardium, Gore-Tex grafts, lots of different things that have been used. Alternatively, you can incise the plaque and then put the graft directly in there while leaving the plaque in place. And an old-time technique would be also plication of the contralateral surface. So actually grabbing some of this tunica over here and excising a portion of it and sewing that together so that it basically off-balances the area of tether. The biggest complaint that people have is that's going to foreshorten the penis, and that's going to likely create an hourglass defect in that area. So Dr. Lehman put this one in. This looks like and I didn't want to take it out, but I don't know. This looks like a trauma to the testicle, and this is a good way to get a testicular rupture. In general, trauma to the penis and fracturing the penis is going to be on the erect penis, and I don't think this guy had an erect penis unless something weird's going on. And so, a flaccid penis is pretty hard to traumatize or damage. It's going to bend. It's not going to rupture. An erect penis is a high-pressure system. That tunica is a very, very strong, stretchy material. But if there's a rapid bend to the penis, and the classic story is someone having intercourse with their partner, slipping out and then hitting, let's say, the pubic bone or hitting the perineum kind of rapidly and hearing a snap and immediately losing their erection and then coming, basically that high pressure blood that was in the penis extravasating into the surrounding spaces, and that eggplant that I described to you is not uncommon. The penis kind of swells up significantly, big purple eggplant, and that needs immediate surgical repair. Otherwise, there's going to be considerable deformity. The other concern in that circumstance would be that snap also leading to a urethral tear. That would need to get repaired concurrently. All right. Doing pretty good on time. So going on to acute scrotal issues, we'll talk about a bunch of these conditions. Let's get started with something that is one of those rare urologic emergencies. So when I was looking at different surgical fields, because when I went to medical school, I was quite, at a certain point, sure I was going to go into a surgical field, and it was orthopedics or urology, and I just realized the ortho guys are always getting called into the emergency room, but there's very few things that a urologist has to come for immediately. This is one of them, and this is something that needs to be recognized, otherwise there can be considerable morbidity as a result of a delayed diagnosis or treatment. So testicular torsion, this is a surgical emergency, and within about 6 hours, that testicle is probably going to become non-viable. It typically presents acutely, and by acutely, I mean this is not going to be insidious. Oh, over the last 4 days, my 15-year-old has been complaining of a little scrotal pain, and it's gotten worse. This is typically waking up in the middle of the night and feeling this horrific scrotal pain on one side. Typically, it's going to be in a pubertal teen. Sometimes you see it in individuals that are in their 20s. It's very rare outside of that age population. We also see it in neonates too. But the classic presentation, and I think that you as students should be aware of, is that pubertal and early 20s presentation. And like I said, there'll be a sudden severe pain. There'll be swelling on the ipsilateral side of the scrotum. Sometimes it can be nausea and vomiting. What's important in this circumstance? Well, first off, the clinical history is absolutely is important, and not relying completely on things like imaging and lab tests and all these other things. Actually listening to the patient and examining the patient and using the brain and moving quickly in these circumstances. So someone's going to show up after probably 2 hours of complaints because they've had to drive to the emergency room. They thought it was going to get better. They may be sitting in the emergency room for a while until they get triage. So the clock is ticking, essentially. This needs to get fixed, or there's irreversible damage to that testicle, and it's going to have to be surgically removed. If it's an equivocal situation, there's value in doing an ultrasound. If the story doesn't fit exactly, it's been on and off, or the exam doesn't exactly fit torsion, these are reasons to get ultrasounds, and the ultrasound may show blood flow on the Doppler aspect or may not, but it shouldn't be I'm relying on my ultrasound to make my decision. That should be an adjunct to the clinical decision making. You can also have events like torsion, detorsion, in which if left alone, it will probably retorsion. There's a good chance if you send the patient on their way without surgical exploration and treatment, they'll ultimately lose that testicle. So from your perspective, you guys are on an airplane and someone says this 15-year-old is having the most excruciating testicle pain ever. Is there anybody that can help? And you're over the Pacific Ocean and you do a quick examination. You see ipsilaterally on the side of complaint, that testicle is swollen and indurated. And this is not a story of, let's say, epididymitis or UTI or orchitis. This isn't something that's been going on for a while and getting worse. This just happened right now. You can make the assumption that the spermatocord has twisted. And which way does it usually twist? I use even in my mind now, because sometimes it's 3 in the morning when you're going to see this, when it torses, it'll tors in. So it's going to rotate medially. So what can you do in this circumstance? You can try to detors it, and that is basically grab that testicle and try to turn it 360 degrees. And which way would you turn it? Think about opening a book. So the right one, you would rotate right. The left one, you would rotate left. So to detors, you open the book, and when it torses, it usually torses in. Oh, and what are some risk factors for having this? Historically, it's felt that maybe the bell clapper deformity is a testicle that has the kind of lateral lay. So instead of being up and down in its longitudinal axis, for some reason the testicle's a little higher riding, and it's got this longitudinal lay. That may be associated with a risk of getting torsion. Does this mean anything? Not exactly. Does that mean if you see somebody with a bell clapper deformity, you're going to say that they need any kind of preemptive treatment? No, it's just something to be aware of. Oh, one other thing that you can use on your examination would be the absence of a cremasteric reflex. So that's when you rub the inner thigh and you see the testicle rise up. So if you see an intact cremasteric reflex, that's a good way to say this is probably not a torsion. It's a nice thing to document. So, hydrocele and varicocele. Okay. So as the testes embryologically is descending into the scrotum from its abdominal position, it carries a tongue of peritoneum with it. Just keeping everybody engaged. Any idea what this tongue of peritoneum would be called? Did I put it up here? It's not up here. Anybody? Processus vaginalis. So this little tongue of peritoneum, this processus vaginalis, will come down, and classically what's going to happen is it's going to get obliterated with time, and the two layers of the peritoneum are going to fuse, and it's going to be an obliterated processus vaginalis. Now, if it remains intact, it can be a source of communication between the peritoneum and the scrotum, so that you're going to see babies that when they're crying, their scrotum fills up with fluid. That's probably an intact processus vaginalis. It's the basic same idea as an indirect hernia, that there's an open pathway. So that would be called a communicating hydrocele. When at rest, it would decompress. You could squeeze out the fluid. And when they're straining the intra-abdominal contents, their scrotum will swell up. And that needs to get surgically repaired. That's going to convert into a hernia if it's not already a hernia, in which you can get peritoneal contents into the scrotum. The other possibility is that same layer is no longer communicating with the peritoneal cavity, but it is still not entirely fused at the level of the testicle. So a portion of it has a space that fills up with fluid. And this can happen at any time. It can be childhood, puberty, adulthood, or even in the elderly years. What's the pathology or concern? If it gets very large and uncomfortable, difficult to get in and out of the car or sitting, these are good reasons for surgical repair. What's important in this circumstance? Rule out an underlying disease. So the thing I would think of would be a testicular cancer. And this is, in fact, a reactive hydrocele. You get so fooled with saying, oh, it's just a hydrocele, let it be. It's important to make sure the underlying testicle is normal. So if it's not palpable because the hydrocele is so big, getting an ultrasound and just making sure that that testicle is okay. So the surgical repair is pretty straightforward, essentially excising a large portion of that hydrocele and obliterating the space where fluid can collect. And instead, if there is fluid, it's going to get absorbed by the scrotal wall. And then varicocele. Okay, so a varicocele I liken to other kind of varices that can be found in the body. They're basically incompetent veins. So you can get varices in the lower extremities and the legs, right? And so this is going to be a dilation of these incompetent veins of the testicle, the pemphidiform plexus. And it's very common, actually. About 15% of young men will have a left-sided varicocele that's not pathologic, so there's nothing to be too concerned about. So think about that. 15 to 20% of men have varicoceles, with a very small proportion of them actually having problems. When will this occur? Well, a lot of times at puberty, when there's sudden increase in the size of the testicle and arterial flow into the testicle, but the veins are failing or they're incompetent, so they're going to dilate a bit more. So I think I have it over here. Yeah. So the left side is going to be a little bit more common in terms of incidence, and it's, like I said on the slide, that the left gonadal vein goes and attaches to the left renal vein versus the right, which goes straight into the inferior vena cava. And that pressure can sometimes be the main cause, that direct hydrostatic pressure. And as a consequence of that, when the patient is recumbent, you should see the varicocele reduce. So that's an important thing to do, actually. In any setting, you're evaluating somebody for a significant hydrocele, have them lie down and make sure that goes down. And if it doesn't go down, we're thinking something proximal is obstructive. And the classic thing would be some kind of tumor classically in the left kidney. Have you guys done kidney cancer yet? Yeah, so that it's one of those interesting tumors that it's only T3 when it's extending all the way to the vena cava. So the path of least resistance, the tumor thrombus from a renal cell carcinoma can extend into the renal vein, travel up the vena cava, cause obstruction of that left renal vein, cause this varicocele. This could be a presenting complaint for someone with a massive T3 renal cancer. And how would you figure it out? It would be a master diagnostician and say, well, I had them go recumbent, and this varicocele didn't reduce. I decided to get an abdominal ultrasound, and I found this cancer. And it's one of those things that you actually use your skill set and use your mind and not completely rely upon labs and imaging for everything you do. So that's one of those few cool things that still remains for us to be diagnosticians. So keep that in mind over the next course of your career, even if you don't go into urology. Get them to lie down for their varicoceles. And so there is a percentage of people that will present with infertility and a low sperm count. And through the course of the workup, the only thing we find is a varicocele. And in that circumstance, there is value of doing a varicocele repair. And why? There's a hypothesis, there's the hot rock theory. So the testicles and spermatogenesis prefer to be about 2 degrees cooler than the rest of the body. That's why the testicle, well, that is the hypothesized reason that the testicles are outside of the peritoneal space, the abdominal space. So when you have all this old blood kind of sitting around in the scrotum, it's warmer, and it's going to keep the scrotum warmer, and consequently, there's going to be less effective spermatogenesis. So in those circumstances, we do repairs, and our repairs can be angioembolization of the renal vein. I'm sorry, the testicular vein, or a surgical ligation of all these varicosities. So it took me a while to fully grasp what was going on here, and so I'm going to spare you having to struggle and scratch your head and go through all the processes to understand how you could ligate these vessels and solve the problem. And I'm actually going to just tell you now. So it's there's three supplies of blood to the testicle, right? There's going to be the and remember the supply of blood that goes to the organ is also tied to its venous return. So there's going to be the testicular artery, and I want to call on somebody because I'm just talking too much. This is, yeah. So my friend up in the front, the testicular artery, origin of the testicular artery, like what's it coming off of? Yeah. So we're going, and that ties to the testicular vein. So the testicular vein is going to go up to the vena cava, or the left side, which is going to go to that renal vein. There's a second supply, and this is like probably 10 points. And I won't call, because this is kind of challenging a bit, the second arterial supply to the testicle. Anybody got it? And you guys have computers open. You could like Google this quickly, huh? So this doesn't happen. Yeah, this doesn't work anymore, huh? Okay, so there's going to be a second supply. It's going to be the artery to the vas deferens. And the artery to the vas deferens is going to be coming off of, anybody? So it's an intra-abdominal organ, so I think of the vas deferens, I think of the internal iliac system. And then the last supply, arterial, and remember, so the venous drainage is going to go that way, and then the last thing is going to be a cremasteric artery. And so the cremasteric muscle is an extension of what muscle? Louder! Yeah, so the internal oblique, and that's going to be basically, what's that source going to be? That's like the inferior epigastric. So these are inferior epigastric arteries. So these are going to be the three supplies of arterial and then consequently venous blood. So ligating the testicular veins, you're going to basically force a collateral flow. And those two alternative systems, going to the internal iliac system and going to the epigastric, which is essentially going to be it's going to be forced through. And those veins are much shorter, and it's going to basically allow for venous drainage without having this big column of dilated veins. Okay, so cryptorchidism. Cryptorchidism is, by its title, is a lost or missing or hiding testicle. A lot of times you're going to be able to feel these. But this is something valuable in the primary care realm. So 3% of males are going to have an undescended testicle at birth. You're not going to palpate the testicle in the scrotum. By 1 year of age, that's going to be 0.8%. So more than 2% of them, it will descend over time. So it just needs to be monitored, but not forgotten. There's still that about 1% of kids that are not going to have a descended testicle after a year of age, and that does need to get fixed. Why do we have to fix it? Like I said before, there's the fact that the testicle does better when it's in the scrotum. So the temperature issue, both for development during puberty and spermatogenesis, hormonogenesis, we want to have the testicle in the scrotum. More so, there's an association with testicular carcinoma. Wow, I've been talking a long time, so let's speed this up. There's an association with testicular carcinoma with undescended testicles, so we want it in the scrotum. We want the child, or ultimately the adult, to be able to feel their testicle, do testicular self-examinations, feel for nodules, masses, things like that, and be able to report it. So if there's a cancer, we can catch it early. And a couple of risk factors would be prematurity. A retractile testicle, you'll be able to grab it, bring it into the scrotum. It may retract back up. Does not necessarily need immediate surgical repair, but does need to be followed up on. So what can be done? It's an undescended testicle. We can give a big infusion or a significant infusion of HCG, which will mimic LH, consequently get the Leydig cells to make a bunch of testosterone, and about 20% of undescended testicles will come down that way. Surgical repair would be an orchiopexy, so freeing the testicle up from its position and bringing it down to the scrotum. So where is it going to be located? So the vast majority are going to be in the inguinal canal, and depending on if the patient's cooperative, you'll be able to palpate it. A lot of these kids will be laughing or crying or whatnot. It's very hard to distinguish the little 1 centimeter testicle. But you have to make that finding. You have to determine if there is a testicle in the scrotum, and if it's not, you got to find out where it is. There's other places that it can be, including in the canal, the inguinal canal, or intra-abdominal. And the higher the testicle is, the higher likelihood it's going to develop a carcinoma, and most certainly an abdominal testicle needs to be removed because of the cancer risk. Here's something important. Disorders of sexual development. So a child is born and it has a penis that looks like this. What's the big thing that should be suspected? I would suspect, or I'd worry for some intersex disorder, and I would not just say, oh, this would get better with time. The biggest concern is congenital adrenal hyperplasia. This child gets sent home and they have this condition. They're going to salt waste, and in 7 to 10 days have a severe adrenal crisis, and it can be life-threatening. So hypospadias and bilateral undescended testicles need to be evaluated immediately for an intersex disorder, need to be evaluated for CAH. Don't make the assumption that this is just a boy with hypospadias. This can actually be an intersex disorder, and these are in fact incompletely formed labia majora, and this is in fact a big clitoris. And here's the meatus, or the urethral opening down here. I don't know if you guys, this is probably within your endocrine section, but the basic defect of congenital adrenal hyperplasia is most commonly like a 21-hydroxylase in the steroid synthesis pathway, and as a consequence, the feedback loop and all that ACTH coming down and pushing the testosterone levels as a byproduct very high in these genetic females, and that's why you're getting this kind of virilization in a genetic female. Just briefly, andropause. This is something that was really kind of popularized in part by industry that was telling patients, if you don't feel good, maybe you have a low testosterone, you'll feel better with this. And in fact, a lot of people do, but there's enough concerns regarding the risks of replacement that there's quite a bit of backlash against that. And the two notable studies that are now being expanded upon was a higher incidence of stroke and heart attack in patients on testosterone replacement. So most certainly people with low testosterone need to be evaluated, and if they have a pathologic hypogonadism, which is not just kind of the normal aging process, that needs to get replaced, and there's lots and lots of reasons to do that. But on the other hand, just kind of borderline low testosterone without any pathologic condition should be not necessarily replaced because of the associated risk. What could be the risks? Enlargement of the prostate. If there's an occult prostate cancer, activating that cancer. Liver damage. Exogenous testosterone is going to suppress spermatogenesis. It's going to tell the testicles and the pituitary that, well, we're doing good, and kind of shut down that access. You're going to get increased levels of red blood cell volume, and that can be, again, a risk factor for the stroke and heart attack and death. It's an abused drug by kind of endurance athletes as a result of that, because they want to get their hematocrit levels higher, their better oxygen carrying capacity. Lots of different ways that we replace testosterone. We don't typically replace orally in America because at higher levels it'll cause a liver disease and liver cancer. Typically we're using something like a transdermal gel, injection therapy, or subcutaneous pellets. Cancers of the penis, very rare in the United States, less than 20,000 a year. Biggest association is poor hygiene, and biggest association with poor hygiene is uncircumcised penis. So individuals that are uncircumcised, not pulling back the foreskin and cleaning on a regular basis, are the ones that are at risk for penile cancer. There is an association with HPV and the number of sexual partners and the use of tobacco. It's usually going to be a squamous cell carcinoma, and other things to kind of consider would be, is this an STD? Is it a inflammatory condition? BXO, balanitis xerotica, obliterans of the foreskin, that which is just treated with a circumcision typically. The treatment's going to be based on its location. A penile cancer of the foreskin can usually be treated with removal of the foreskin. A local lesion that's superficial sometimes can be removed, or partial or total penectomy based on extent of disease. All right, this is, well, let's see, how much more we got here? Okay, this is kind of an important one. We'll shoot through this though. So the vast majority of testicular cancers are going to be germ cell tumors, so related to the spermatogenesis process, and not those interstitial cells. So 5% of tumors are going to be things like Leydig cell tumors or Sertoli cell tumors, but the vast majority and more dangerous type are the germ cell tumors. Seminomas are going to be the most common single histology associated with a pure tumor, but oftentimes we see mixed histology. So you have different components like embryonal, choriocarcinoma, and whatnot. I'm going to skip the case study and just say what's the evaluation. We're going to see a patient that's presenting with a painless mass. They may say that they got hit or hurt. Classically, they just noticed their scrotum because they got hit or hurt. This mass is not usually hurting. It's not the result of the trauma, but they're just now aware of it. So it's going to be a mass in the scrotum. It's typically a delay in diagnosis. The one important factor is localized disease is very curable. An argument for having all teen patients start doing testicular self-examination, telling them in the shower once a month, reach down, just feel and feel the testicle, make sure there's nothing that feels like a knuckle. Evaluation is going to include an ultrasound to confirm that this is a solid mass. If that is a solid mass, we're going to want to look into the retroperitoneum and the lungs, where there's going to be sources of metastatic disease. Our tumor markers are very, very important, both in terms of staging and then subsequent confirming cure, because let's say you take out the testicle and your tumor markers don't normalize, you know that there's likely disease elsewhere. Beta HCG, alpha fetoprotein, LDH. Those are our standard 3 markers. Here's a pretty good testable point. If there is an elevation of AFP, by definition, it's not going to be a seminoma or a choriocarcinoma. Treatment and inguinal orchiectomy. Why would we do an inguinal orchiectomy instead of a transscrotal orchiectomy? Because this is a really well-defined disease that's one of the kind of few diseases that we've learned surgical cure. We know the lymph pattern of this disease, and we don't want to disturb it because we can catch where the disease is going to go next, and if we clean out that next place, the lymph nodes of the retroperitoneum or whatnot, we will be able, or we can target it with radiation, we can cure the patient and have incredibly high cure rates for metastatic disease. We violate that drainage pattern by going through the scrotum. We've just basically opened a new pathway for drainage and the possibility of basically allowing, if the disease is spreading, to go into lots of different places. And so our chemotherapies are going to be bleomycin, etoposide, and cisplatin based on stage and histology and the extent that it's needed. Radiation can be used for stage 1 seminoma, although we're getting away from that. And with the modern kind of era of having lots of imaging and fairly compliant patients, we're actually getting into a lot of surveillance, whereas we used to kind of routinely, for stage 1, be giving maybe some chemo or radiation or surgery. Now with surveillance, when we're imaging people regularly, if there's no evidence of recurrence, can avoid those more invasive treatments. Okay, 2 more minutes and we'll take a break. Male sexual dysfunction. So risk factors. When someone comes up and says they have erectile dysfunction to me, and they go, "Why did I get this?" I'm going to say, "Well, it's multifactorial." And how do you get an erection? There's going to be blood flow that goes into your penis, and that blood flow is arterial. It's going to be impacted by things like your diabetes, your obesity, your smoking use. These are all things that are going to cause atherosclerosis. Concurrently, that blood that goes into the penis is going to need to get trapped. You're going to have a veno-occlusion. There's going to have to be enough pressure, and these veins are going to have to compress so that you can actually keep the blood in there. So that prior trauma where you got that pelvic fracture and disrupted some of those vessels, probably those veins.